Today we're visiting Fox Chiropractic, which is one of the offices that we also see patients in. We've known Dr. Howard Fox and Daniel Fry for a number of years and worked with them. They're very dedicated chiropractic physicians who provide treatment for musculoskeletal injuries to their patients. I've been very impressed by their level of dedication and care and individualized care that they offer. We'll specifically focus on two areas of treatment that they provide access to. One is shockwave therapy, which is very effective in treating musculoskeletal injuries, including shoulder, knees, feet, spine. And then spinal decompression, which is done for individuals that have neck problems and back problems, particularly with herniated disc and radicular pain. They want a method to improve their pain and avoid surgery. The first one is shockwave therapy, which they have incorporated in their practice. And I have some personal experience. We've used it in patients with orthopedic injuries, including plantar fasciitis, elbow tendonitis, and have had excellent results. Dr. Fox can talk about his personal experience. Also, we want to talk about decompression therapy, which is an option for treatment in patients with herniated disc or radiculopathy, especially if they want to avoid surgery. This is an option for treatment for them, and it can have very beneficial results. So let's talk about shockwave therapy. What is your indications for when you offer patients shockwave therapy?
So extracorporeal shockwave, or stem wave, is used in a lot of cases, mostly musculoskeletal injuries, but some other conditions. We use it a lot in tendonitises and tendinoses, including, like you said, lateral epicondylitis. Tennis elbow is most common. We have a lot of pickleball players now. They're all getting treated with it. We're taking injuries that were 6 to 12 weeks down to 3 days to 9 days, maybe 3 treatments. We use it in plantar fasciitis really, really commonly, works extremely well. And then we're using it in everything from the very, very deep tissues in the shoulders and the hip, which are in the labrums, to all the surrounding musculature around it. Once a week, we're doing shockwave. The shockwave, again, brings in microvascular stimulation, so it brings a lot of blood into the area to help healing. And then it brings in mesenchymal stem cells. You make them, your body produces them. This brings a messenger RNA into the area, which stimulates those stem cells to draw right to wherever we're putting these pulses. And that's how this works and how we improve everything. So what's your stomach? Sorry. We use sound-weighted ultrasound gel. The shockwave is a sound wave. Standard ultrasound treatment goes at 80 feet per second. Shockwave is at 3,000 feet per second. It is a significantly more powerful tool. This is set at a 10 level. Anything over 16 is going to be very pain productive. And you'll hear that sound. Each time you hear that sound, that is a shockwave being generated. So in her case, it's right over the disc and right over the facet. So we've already done a pattern on her. We know where we're going with it. And we're going right over the sacroiliac joint at the top. And then we're going to be coming across at L5. And then all the way to the other SI joint. And in her case, we're going to be putting in 600 pulses. And you can hear the tone change based on how cleanly it's getting into her tissue. Part of that is the angle that I'm holding it, and part of it is the resistance of her tissues. That gives us feedback. The other feedback we ask for from patients is this. Is there a spot that is particularly tender that you can feel? If there is, we will focus on that tender spot because that's the area that we want to get producing more of the M2 prostaglandins versus the M1 prostaglandins. All of that is correlated with her MRI findings. And that's how we develop our treatment pattern. But like I said, day one, you're sweating a little bit when you do this. It is uncomfortable. Right, Kristen?
Yes.
But after that, it's really a mild level of soreness. I can tell you this because I am both a doctor and I'm a patient. I have a labrum tear in my left shoulder that I'm going to have Dr. Fry show you what that looks like when you make a person sweat.
We wanted to discuss shockwave therapy treatments. Again, it's used for multiple musculoskeletal, but one of the most common is shoulder problems.
So my shoulder problem is that I have a confirmed MRI torn labrum. So I've had it, we healed it, it's good. And my dog, who is 130 pounds, was kind enough to yank my arm really hard and re-tear it about 3 months ago. So we've been working our way through it. I must admit to being a really bad patient. Even though I have Shockwave here in my office and I come every day, you'd think I do my therapy. But I have been negligent because I've had very little pain. After our first month of treatment, I don't have any pain ongoing. What I have is loss of function. I'm a surfer and I cannot paddle with my left arm. I can't get this motion. I'm good, God, so good. So I really need to be more diligent about it, but I've been lazy and playing a lot of pickleball instead, which is a bad idea in life. Don't play pickleball instead of surfing. So Dr. Fry is gonna administer Shockwave to my labrum of my left shoulder. So we'll roll up my sleeve.
Posterior, anterior.
Posterior. And we've already gone through the mapping process here. So my spots are right here, right in the middle, and then right here. And we're gonna angle up this way, dropping my arm down so that we get the wave more into the labrum and less onto the head of the humerus. So if you watch my face closely,
I'm gonna start angling now.
At 14, right, go up again, go interior, right there is a fairly sharp pain. We're going to stay right on that. But if I go from 14 to 16, it gets a little more intense, and that's about as much of that as I want. 19 is a distinct, sharp pain. Stay right there. And what's super interesting about this pain is it is not at the surface where that wand is touching my skin. I do not feel a thing there. Where I feel this is about 1.5 inches inside my shoulder. So that far down inside is the point that the two sound waves are converging and focusing on, and that is literally where I feel it. And in this case, we want to stay real tight onto those spots that are real tender, right there, and it's patient driven. We get feedback from the patient as to where we're going. So Dr. Fry, when I say there, Dr. Fry staying right on it. And it's interesting because if he changes that angle, if you just don't move the head, just angle up like this, I lose it. No pain at all. Go ahead and come back, and right there. I'm right on it. It is where the beam is going. It is super exact, down to a pinpoint. Now this type of shock wave is called the stem wave. It has a broader wave, a little bigger than some of the other ones. There are ones that are so focused that you have to use a diagnostic ultrasound at the same time to place it where you're going to place it. And that's how some machines are best done that way. They're very time consumptive and they're a little harder to use. Some people like them better. I don't think for what we're doing in musculoskeletal injury, you need to have that. I think if you were doing things where you were really working on very, very fine tears, you would be better served by that. Or if you had somebody who you were trying to break up the surface of a joint that had some calcium deposition on it, then the ultra focus may be a better tool. But I like this one. It was very successful with me. My initial treatment that I had was done by Dr. Gen, who works for the Marine Corps. The toe, right here, my toe joint of this equal to my thumb is very degenerative. It did not move for 1 year. I was a soccer player and a surfer, and I got beat up toe. That's it. We treated it, and I will tell you that I was tapping out from the pain. I could not take it any higher. But this is how the Marines work, And they were moving that joint. And when I got done, I'm telling you, I could bend the top part of the joint before. I could not bend this. One treatment, I could bend that joint, just like that, and it held relatively pain-free. I would say down to a 1-2 for 3 weeks without even a secondary follow-up treatment. It was extraordinarily impressive to the point that I bought the machine. And then we're using it in everything from the very, very deep tissues in the shoulders and the hip, which are in the labrums, to all the surrounding musculature around it. We're also incorporating it into our non-surgical decompression and using it to stimulate stem cell formation and drawing stem cells into the areas in both cervical spine and lumbar spine non-surgical decompression cases. So decompression protocols are well established. Their single level is generally between 18 and 22 treatments. They're done 3 days a week. They're 30 minutes in length. They are done with 50% or more of the body weight of the person. And the biggest, most important part about non-surgical decompression is that you have load, then you have load release down to at least 50% of the previous load, and then back on load. That cycling and the isolation of levels is what makes decompression not traction. So we recommend it in not just herniations. We recommend decompression in bulges, in ruptures, and in herniations that aren't too far gone. If the herniation has separated from the rest of the disc material, which is called sequestration or isolation of the disc, that's when it tends to leave the non-surgical decompression field and become a surgical matter.
What about spinal stenosis? Now again, just
Sure.
to explain, it's a condition where there's overgrowth of the bones, facet joints, and so forth, causing compression on the nerves, where the individual has ongoing pain that goes to their lower extremities, usually worsened with prolonged walking or standing. Is there a role in decompression therapy for spinal stenosis?
There can be a role in spinal stenosis if the spinal stenosis is at least partially generated by the soft tissues, by the disc intruding into the space as well. You have both hard tissues and soft tissues that make up the foramen, the holes through which the nerves exit. As long as part of that is disc material, decompression can be helpful. If it is pure bony overgrowth, that's when spinal decompression is not going to work. It's just bone, and we'll open it up, and then as it closes down, that bone is still there. It won't have a positive effect.
So to do that, are you reviewing the MRI? How are you?
There is no such thing as a decompression patient in this office that has not had an MRI within the last year.
And so you decide if, based on the level of compression, is there a candidate for decompression?
Yes,
therapy?
and oftentimes, especially in our office, oftentimes they have orthopedic or neurosurgical consultation either first or second. Because sometimes we'll look at it and say, look, you're 50-50 here. Our goal is to avoid this surgery and you not have to compromise your life. But you may only have a 50% chance of doing so. When that's the case, we're gonna refer you to an orthopedic or neurosurgeon, and they're gonna say, nope, you need an emergency surgery, because nope, it's too far gone. Let's not waste everyone's time and money. Or, yes, let's try this. If we succeed, great, and if we don't, I'll see you in a couple of months. Well, let's do a low back pain non-surgical decompression setup. And she is an existing lumbar spine non-surgical decompression patient. So I'm gonna go through the setup. The setup is relatively simple. We're gonna harness her lower half, her upper half, place her on the machine, and she's gonna lay down. We'll set her up. Kristen, you wanna come over here? Okay, so you're gonna step into the big hole, as you know. One hand right here, please. The setup is relatively simple. It's harnessing. A lot of people will say, oh, I feel like I'm gonna go jumping out of a plane or something. We tell them not to. While we do this, patient's usually very comfortable. There's no issues with it. We are gonna make it pretty snug in a second. It's all about, sorry, Kristen. It's all about balancing and making sure it's all even.
So pretty tight.
It has to be firm. It also has to be firm underneath the ribs. So the bottom half is really easy to harness. The top half, on the other hand, in some patients is really hard to harness because they just don't have separation the way they're built of their abdomen and their ribs. So you have to be really aggressive about that. No matter what we do when we harness them, go ahead and step up, Kristen. Once we lay them down, their abdominal tissue goes flat, so we have to re-harness them a little bit. So you can see I've already set this up for Kristen. It gaps right at her L4, L5. So level gets set two ways. We want our gapping at our level, and it's all automated. If a person has vertigo or something of that nature, we can put their head up higher. If they have cervical spine issues, we don't tend to use a triangular block. We tend to use a rounded block. We tell them that we're gonna lay you down slowly, oops, and then we're gonna put this up underneath her head because she has an existing cervical spine injury. We don't wanna make that worse. And then we're gonna harness you in. So I'm gonna lift up here, I'm gonna pull you gently this way. And then I'm gonna lock the harness in the top half of the machine. So there are patients with knee injuries who cannot go over a triangular block. And for those patients, we actually had a custom one made that lifts their legs and holds them at 90-90. So their legs are up here. It's not from the device manufacturer, but if you turn around, you'll see it right on that one. That block is designed for people who have significant knee injuries and cannot have this angle over their knees. From this point, Kristen's gonna lay there, and I'm gonna set the level. So this is her level, and each level changes the angle that the pulling occurs from, and that's how you isolate angle. Everybody preset in here who's an existing patient. It shows you their last visit, what their weight is, what their load is, and then we just go on to next, and we hit run, and it's all touchscreen driven. It's very, very simple. Kristen, loads, so you can see the belt just tightened. Kristen, you're gonna start to feel your load. I'm gonna tighten this a little bit while you're laying down. Sorry. So I actually tuck it in here to get the Velcro right up underneath her ribs. My own touch. The last thing we're gonna do is change the angulation of your pelvis and set the pelvic angle, just like that. And now, Kristen, you're gonna lay, you're gonna feel the load come up. And you're at 62 pounds, you're gonna apex at 75 pounds. What you see here is the time, current load, the treatment cycle. So this is the first of 18 cycles, each cycle being 90 seconds long. This is her maximum load. That's her treatment angle. Her minimum load is half of this load. Here she's just about at her maximum load. Then it's gonna drop down to a half load, which is her minimum load. So this is the load we're sending in. This is a load that the patient is actually receiving because this is what's called a decompensation load. This is what her body's taking out. Any sort of sensitivity to the load, their body is gonna fight against the load. I mean, that's just nature. And what we see is here how much she's fighting against it. Kristen's line is basically flat. There's no decompensation occurring. So everything we're putting in, she's getting. If we give her 200 pounds of load, and always we get more, give me more, I don't feel anything. Your body feels it. If we put in 200 pounds, your body's gonna resist 100 pounds. So all we did was increase the risk. No more got into your body. This is why this is such a great device and such great technology. It's measuring 100 times per second how much load is happening in there.
So are you feeling it? Are you feeling the...
Yes.
Is it painful?
No, not at all.
What was your pain level before the decompression started?
I'm usually at a solid 8 or 9 when I
So
come
what
in.
what is it now?
It goes down to probably like a 3 or 4.
And what about when you go home? What do you notice? Is there a up?
No. It actually, you're supposed to be wearing a brace after.
Right.
And it helps you just, if you need to bend over properly, just to where you don't mess up what you've basically done and made it worse.
What level does your pain usually stay at, say, by that evening, first day?
I would say like a 3.
So you're going from an 8 to a 3 on day of treatment. That's pretty solid for the size herniation that she has. And she has a herniation. You don't mind if I tell them that, do you? Okay.
So she tried shockwave therapy?
We just started Shockwave. We do Shockwave on Kristen about once a week. The whole idea with Kristen is that we're trying to not have her have surgery. She has been told she is a surgical patient, right? And we are avoiding that process. That is our entirety of our goal here. If we get her managed down to a 2-3 without pain shooting down her leg and numbness in her leg, and she has to manage through life with a 2-3, I'm okay with that. You know, I'd rather it be a 0, don't get me wrong, but a 2-3 we can manage and do all the activities that we do in life. We can ride horses, we can play hockey, you can play pickleball, you can do everything you want to do at a level 2 pain. That's what a level 2 pain is. I feel it, but it doesn't stop me from doing anything. That's the definition of it too. If I can take you from surgical to a 2, you should say thank you every time we do it.